Welcome. Thank you for joining us today. My name is Amy Sam. I am the Health Education Project Specialist at the Maxwell and Eleanor Blum Patient and Family Learning Center at Mass General.
Hello, I'm Anna Wise, and I'm an intern here at the Blum Center.
Before we get started, I just want to go over a few items with you all. Please note that today's session is being recorded for educational purposes. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Please note that you are in listen-only mode. Everyone has been muted so we can hear our guest speaker today. If you have any questions for our guest speaker, you may use the chat feature, which is located at the bottom of your screen. You'll have time for in the end. Only Blum Center staff and our guest speaker will see your questions. Please do not share any personal medical information or questions in the chat. If you have a personal medical question, please ask your doctor. Lastly, at the end of today's session, you'll be directed to a brief survey, which we would like to ask you to help us complete. Your feedback is important to us as we plan future programs. All right, so next I'm going to turn it over to Anna, who will introduce you all to today's guest speaker.
Hello. Dr. Bowman is a board-certified naturopathic doctor with residency training in internal medicine and fellowship training in neurology. He is an instructor in neurology at Harvard Medical School and director of clinical trials at the McCann Center for Brain Health at Mass General. He has an interest and passion for the development of novel dementia prevention approaches, including natural products and more comprehensive lifestyle changes tailored to the individual. In recognition of Brain Health Awareness Month, Dr. Bowman is here to give a talk on the nutritional risk for cognitive decline. Please join us in welcoming Dr. Bowman.
Thank you very much. So I'll go ahead and get started, if that's okay. Thank you for the introduction. It's a pleasure to be here. This is my first experience in the Blum Learning Center. I'm a new faculty member that joined the Department of Neurology late last year, and I serve as the Clinical Trials Director at the McCann Center for Brain Health. And the title of the talk today is Nutritional Risk for Cognitive Decline, the Good, the Bad, and the Ugly. So today's outline, what I'd like to try and cover in about 45 minutes and leave a little bit of time for some discussion is to provide a little bit of context around Alzheimer's disease and breakthroughs that have occurred over the last 25 years that are relevant to what we'll be speaking about in terms of nutrition and metabolism. Also, I'd like to share our research strategy and approach. And then I'd like to introduce some of the fundamental mechanisms of Alzheimer's disease that may be well suited for nutritional interventions and nutrients that are implicated in each, leading to formal clinical trials to date. Is that at that point, I'd like to back up and discuss dietary assessment in older adults at risk for dementia and briefly discuss a couple of the tools that are currently available, subjective and objective measures. And then I'll take you through a series of studies that we've been involved in identifying dietary patterns or nutrient biomarker patterns associated with brain health from several cohorts and clinical trial studies. Share with you a recently completed omega-3 fatty acid trial that we led, and then some exciting results over this last year, not only in terms of future directions in the field related to nutrition and dementia prevention, but some recent major phase 3 clinical trials that have been conducted around multivitamins and minerals, some conducted by faculty here in the Harvard network. And then we'll finish with some further resources to stimulate some discussion. So just a snapshot of our research strategy involves utilizing cohort studies where we observe people over time and measure things from nutritional status to cognitive function to brain imaging Sometimes we have lumbar punctures where we collect cerebrospinal fluid and measure proteins that are relevant to Alzheimer's disease. And then we have a preclinical side, and here I'm excited to join forces with Dr. Rudolph Tanzi, who leads the Genetics and Aging Research Unit in the McCann Center for Brain Health, who has really been a leader in developing what he calls Alzheimer's in a dish, that can provide rapid screening of natural products or repurposed drugs or combinations thereof. They can give us more leads in terms of what should be translated into clinical trials and looks promising. So what we do is we take that preclinical information, we take the information we gather from cohort studies, and we meta-analyze that, and we make a determination what really should move forward into clinical trials. And in terms of nutrition, dietary guidelines, we're thinking about different groups and different regulatory pathways. One is basically just providing education to consumers and people in terms of what they should be eating, what they should be avoiding, these type of things. But then there are regulatory paths for developing therapies, and there's really two categories: medical nutrition and really drug development, or what we call novel therapeutic nutrition. So these are areas that we hope to fill these buckets, if you will, and this is how we get there. So over the past, I would say 25, even 30 years now, some of the big breakthroughs in the Alzheimer's field have been related to understanding the natural history of the development of the disease, and also the genetic factors that are driving the disease. So the causal genetic loci have been pinpointed, and those are listed here. But there's also some risk loci, meaning there's not full penetrance. Meaning if you're carrying these genetic factors, it doesn't mean you'll end up with the disease or a more rapid rate of cognitive decline, but you're at higher risk. And of course, apolipoprotein E carrying the 4 allele is the most dramatic or highest risk associated with that genetic factor. And what I've done is just kind of from a high level, just trying to demonstrate some of the mechanisms that these genes are involved in, from lipid metabolism to protein trafficking to inflammation. And there's overlap there. And this will keep coming up as we move through the presentation. I also wanted to mention other features outside of classic Alzheimer's disease pathology and these genetic factors that are related to that, but also the vascular contribution, so that the health of the small blood vessels in your brain. And there's even some genetic papers out, and some from our colleague, Dr. Jonathan Rosen, looking at white matter lesions or small vessel disease in the brain and genetic factors that place people at higher or lower risk. So the aspect of temporal development of Alzheimer's disease, so moving from people as they age, normal aging, into what we call this preclinical phase, into a mild cognitive impairment and a full-blown dementia. So people that are destined to develop dementia, when we go back and we look at factors that predicted that, we have a pretty good idea of factors, how early the pathology begins. And we know now that it begins 10 to 30 years before you start to see the cognitive decline. And that's characterized here in this graph. Now, from a therapeutic standpoint, there are 3 areas that I like to at least introduce. Most of the clinical trials have been focused in what I call the tertiary prevention and treatment stage. So this is trying new therapies in people that already have mild cognitive impairment or dementia. Now, we know now that those people probably have pathology that has built up over decades by that time. It may be too late in the process to be intervening and hope for dramatic prevention at that point. Then you have secondary prevention, and the way that we define this is you're delaying the onset of cognitive decline in adults with risk factors. Either they have signs of pathology that we identify either in the cerebrospinal fluid or using neuroimaging, but they don't have cognitive deficits yet, or they have small vessel disease or energy deficit. so we call that secondary prevention, meaning we see that there's something developing there that puts them at high risk for an Alzheimer's type dementia, but they don't have it yet. That may be a better suited time to intervene. And then there's primary prevention, which I think is probably ideal, but it presents challenges in terms of the design and the operations of the trial, where you just try and delay the onset of any Alzheimer's disease pathology, for example, developing at all. Now, I will introduce what I call the nutritional risk index. Now, this is where a tool that can identify nutritional abnormalities, and conceptually, we're thinking that disturbance is even upstream from this primary prevention. So there's disturbances in the nutritional factors, or the brain's ability to meet its nutritional demand, and that process then leads to a cascade leading into pathology. So that's a relatively controversial statement, but I'm going to present some data today that in support of that. So in thinking about particular mechanisms that may be well suited for nutritional intervention, these are 6 domains of interest that we've published on. And of course, it includes cerebral energy deficit. So we know that the brain has a remarkable demand for glucose, and that there is some glucose disturbance and bioenergetic disturbance in Alzheimer's disease. The classic tangle and plaque burden that deposits in the brain, the tau and amyloid aggregation, classic hallmarks of Alzheimer's disease. And of course, the epigenetic evolution can be modulated through nutrition. That may have influence in preventing cognitive decline. Synaptic dysfunction or gapping of the synapse leading to neuronal loss can slow our cognitive abilities over time. I already spoke about the vascular contributions and inflammation. So each of these areas may be important to identify what track an individual is on before intervening. And that would be, a concept that's described in precision medicine, but maybe we'll call it precision nutrition. So I just want to give a few snapshots of some studies that we've done on each of these domains. So the first one is cerebral energy deficit. And just the end of last year, we published a major 2.5-year effort, a review on really a new direction in the field in terms of developing therapeutics focused on nutritional metabolism and cerebral bioenergetics. So how do we identify disturbances in the energy metabolism in the brain in individuals, and then how do we remedy that? So this paper, I'm not going to go into these details. This is a few of the figures where we describe the cell-specific changes in Alzheimer's disease and what are the implications of nutrient delivery and utilization in the brain. We have mapped out the robust nutrient transporters that exist at the blood-brain barrier and also the blood-CSF barrier, or the core plexus. We've also characterized the literature looking at some key nutrients and studies that have looked both in the circulation, in the bloodstream, and also in the cerebral spinal fluid to understand what ratios seem to be ideal in terms of people that have Alzheimer's disease versus people that are maybe age and gender matched that don't have the disease. Are there differences in the delivery of nutrients in these populations? And there is some evidence to support that. And we've isolated the transporters and location of these particular transporters that are responsible for shuttling nutrients into the brain. The transport mechanisms here that we focused on are, of course, ketones and glucose that support energy metabolism, DHA, the primary omega-3 fatty acid that's enriched in the brain. And then we know that there are several vitamins, amino acids, and trace elements that have carrier transport mechanisms across the blood-brain barrier. Some nutrients can pass passively through passive diffusion. And then also waste and high levels of nutrients that people may take. There is a mechanism by which these are removed from the brain. And of course, this is the blood-brain barrier cartoon here at the microscopic level. And then this is the choroid plexus or brain CSF barrier. And the anatomy is a little bit differently. The cells are a little bit different, and there's some aspects that may be important in terms of understanding the role of nutrition in supporting brain health. So coming back to another study related to more of the hallmarks of Alzheimer's disease, the dense core plaques and the nerve fibrillary tangles that characterize Alzheimer's disease historically. This is one paper where we developed an assay using liquid chromatography mass spectrometry, looking at the one-carbon metabolism metabolites. So homocysteine-lowering B vitamins and other one-carbon metabolism participants in red here are characterized in this new panel, both in plasma, RBC or red blood cell, and cerebrospinal fluid. And in the Swiss brain aging study, which includes 120 people, 65% female, mean age of 70, we measured both blood and CSF levels of these one-carbon metabolites. And we found some interesting findings. So for example, it appears that homocysteine-lowering B vitamins, including vitamin B6, folate, and B12, and other one-carbon metabolism participants appear to explain tau rather than amyloid pathology, meaning in this study, we weren't able to demonstrate any relationship between this pathway and amyloid pathology. Everything was related to tau pathology, and that's represented here by these correlation scatter plots. For example, higher CSF of the active form of folate, 5-methyltetrahydrofolate, was associated with significantly lower CSF p-tau 181. Okay, that's shown in the upper left plot above, and also CSF total tau. So that's here. So you can see the inverted. So higher CSF levels of this active form of folate is associated with significantly less CSF tau burden. And then in contrast, we see that S-adenosyl homocysteine, the precursor to homocysteine in the CSF, the higher that is associated with greater CSF tau, and also greater CSF p-tau 181 represented here. We also show that plasma homocysteine, so in the circulation, blood levels of homocysteine, which is a sulfur-containing amino acid, it's shown here that becomes elevated for a couple different reasons, but one reason can be driven by B vitamin status, and it can be lowered through B vitamin status. If that is elevated, we also see a mild to moderate increase in the CSF p-tau 181. The last thing I wanted to mention is that this relationship between plasma homocysteine, okay, that can be lowered by certain B vitamins, and its relationship to CSF p-tau 181, one of the major measures of Alzheimer's disease pathology, seems to be irrelevant in people that are not ApoE4 carriers. So if you're carrying the E4 allele in ApoE, it appears that homocysteine is very, very important. If you're not carrying the E4 allele, it appears that plasma homocysteine levels lose its relationship with p-tau 181. So that's something to follow up on, and may explain some of the failed interventions testing B vitamins in people that don't distinguish between ApoE4 carrier status or not. So coming back to this, I just wanted to introduce a clinical trial that we have just completed that's really targeting this neurovascular dysfunction and inflammatory mechanisms. So this is a trial that was completed at my previous institution at Oregon Health and Science University. It was funded by the National Institute on Aging. We enrolled 102 people and followed them over 3 years and randomized them to an omega-3 supplement versus a placebo. The interesting thing about this study is it was completely biomarker based, meaning the outcomes were neuroimaging parameters, looking at white matter lesions and diffusion tensor imaging that gives us some reflection of neuronal integrity, the integrity of the neurons. And so we enrolled people 75 and older that were non-demented, and it required a blood test and a brain scan for enrollment, meaning people had to have suboptimum omega-3 status in the blood, and they also had to have white matter lesions, or the mechanism that we thought we were that we were indeed targeting with the omega-3s. People had to show signs of that pathology. So this is back to the context that I introduced. This would be a secondary prevention phase 2 trial on that basis. So the 3-year change differences between groups on white matter hyperintensities was the primary outcome, and diffusion tensor imaging was a secondary outcome. And I just wanted to give you one quick result from that trial. It's currently in revision for publication this year. So in the intention to treat analysis, meaning everybody that was randomized, you can see here that in the active group, there appears to be a little bit of a slower decline in neuronal integrity over time, whereas in the placebo group, it's a little bit more exaggerated, but it doesn't reach significance at a 0.069. However, in a pre-specified analysis, we stratified the treatment groups by those carrying the ApoE4 allele and those not. And those not carrying this genetic risk factor, again, we see no effect of the omega-3s on neuronal integrity over 3 years. However, we see clear separation in people that are carrying this genetic risk factor for Alzheimer's disease, where people taking the omega-3 had significantly slower decline in their neuronal integrity compared to the placebo. So now I'd like to just back up, excuse me for just 1 second, and ask the question, so how do we best assess nutritional status, or what I call nutritional risk, for cognitive decline in older adults at risk for dementia? So to move towards this, I'd like to share a pilot study that I conducted when I was a fellow, again in Oregon, where we enrolled 40 people that were cognitively intact, older adults. Half of them were cognitively intact, meaning cognitively normal, and then 20 adults who had amnestic mild cognitive impairment. Okay, a specific type of mild cognitive impairment where you see memory recall is disturbed, but the other aspects of cognition appear to be intact, and there's no functional impairment. Okay, and then everybody was matched on age, and we had a baseline assessment where we administered a food frequency questionnaire, and then ran a nutrient biomarker panel and had cognitive examinations, and then had everybody come back 1 month later and redo the analysis so that we could look at how reproducible the food frequency questionnaire was, and also the nutrient biomarker panel, and see whether there are differences by cognition. So this was the first study to look at standard dietary assessment methods, which includes the food frequency questionnaire, and whether or not cognition can modify its ability to reflect what people are really consuming. So before I go into the results, I just wanted to share that there are some validated methods of a dietary assessment that exist. These include 24-hour dietary recall. Typically in research studies, there's multiple time points where these are collected. So this requires somebody to fill out and recall what they've eaten over the last 24 hours, from breakfast to lunch, dinner, snacks, and then that is then computed into an estimate of an overall dietary intake. There's also dietary diary, where somebody takes a document home and they record each day what they're eating and bring that back into the clinician. And then by far, the most utilized assessment method on diet in large longitudinal studies across the globe is what's called the food frequency questionnaire. I think here, Walter Willett in the School of Public Health, Dr. Walter Willett, was the first to create this. I believe he did his Career Development Award developing this with support from the NIH, a validated food frequency questionnaire that basically individuals write how frequently they're eating a particular food over a certain period. And that correlates, it turns out, quite well with the volume of food eaten. And then from there, you can extrapolate what people are eating using databases that exist, the USDA, for example, on nutrient contents of food. Now, where do nutrient biomarkers lie? So nutrient biomarkers have not been validated yet. So this study was one of the first to look at nutrient biomarker validation against a validated questionnaire. And then I just wanted to mention that there are new technological, a variety of technological advances in dietary assessment that exist, from audio recordings to image capture. And we're not going to talk about that today, but I wanted you to be aware. So this study was testing the hypothesis whether or not nutrient biomarkers are valid and more reliable indicators of dietary intake than subjective measures, where you ask an individual what they're eating in terms of the food frequency questionnaire. Now, in other fields, in cardiovascular disease or cancer or diabetes, the primary outcome that the investigator is interested in is not cognition. And so when it is cognition, when you're interested in understanding risk factors for cognition, but you're giving an evaluation that requires cognitive skills in some terms, you run the risk of leading to biased results. And so on the other side, nutrient biomarkers have not really been validated. There's a lot of different assays that can be used. There's collection and handling challenges to get reliable measures. I think historically it's been a major issue, but I would say over the last decade, with advances in analytical chemistry and omics science, these can be robust measures. But again, this study was conducted in 2011, so that was before the evolution of the omics era. So we were testing whether or not the nutrient biomarkers could outperform the food frequency questionnaire in people that were at risk for dementia, our target population. So this is looking at vitamins, minerals, and lipids in the total population. Is a small pilot study, but nevertheless, we looked at the relationship between food frequency questionnaire derived nutrients and its nutrient biomarker. And what we want to see here is we want to see a positive correlation, meaning those that reported eating higher ascorbic acid or vitamin C should have a positive correlation coefficient with the blood. So what we see if we look qualitatively is that there are some nutrients that perform quite well. So for example, the carotenoids, xanthophylls, actually perform quite well. EPA and DHA are quite significant. So those that are reporting eating those foods that have those nutrients in them correlate quite well with what you see in the bloodstream. Magnesium and selenium are going in the opposite direction, which is a little bit hard to understand. And many of these have negative relationships, meaning people are reporting higher intakes, yet the bloodstream is lower in terms of concentration. If we divide it by those with mild cognitive impairment and cognitively intact, you can see that there's many more negative coefficients in the MCI. So there's poorer performance qualitatively in the MCI than there are. And then these significant relationships in the total populations are strengthened as we remove those with MCI. Another way to look at this is to determine, look at some of the plasma B vitamins, folate and B12, and how they correlate to plasma homocysteine that I introduced earlier, and then determine whether or not FFQ-derived B vitamin intake relates to homocysteine levels. So clearly we see what we should see. So people eating that have higher folate levels in the bloodstream have lower plasma homocysteine levels. So homocysteine can be lowered with folate, so that makes sense. And then we also see the same relationship between vitamin B12. So plasma vitamin B12 levels are associated with lower decreasing plasma homocysteine levels. But when we look at dietary folate, we see really no relationship to plasma homocysteine. Okay. We look at dietary vitamin B12 reported through food frequency questionnaire. We see no relationship here. So I think this begins to build the case that perhaps understanding the nutrition that the brain sees in the bloodstream may be more informative at early stages than food frequency questionnaire reported data. The food frequency reported nutritional data may not actually reflect what you're seeing in the bloodstream, and yet the bloodstream seems to be a robust predictor of brain health. So let's go a little bit further. If we, this is the panel of the nutrient biomarkers that we repeated. If we go a little bit further with the nutrient biomarker panel, we generated intra-class correlation coefficients, and for the general public, what this means is that these bars here, the longer that they are, the more stable that the biomarker is in this population. We used plasma cholesterol as a benchmark. So plasma cholesterol has an intra-class correlation coefficient of 0.92. And you can see that many of the lipids, for example, the omega-3s, DHA and EPA, are at least as reproducible. Total polyunsaturated fatty acids are also perform quite well. So anything above 0.40 is considered fair to good reproducibility. Anything above 0.75 is considered very good. And we would say that maybe excellent would be above cholesterol as a benchmark. But even some of the vitamins, vitamin D, beta-cryptoxanthin, vitamin B12 that we discussed, lutein, zeaxanthin, vitamin E, alpha tocopherol, the carotenes, folate that we discussed. So many of these, if you do a very, very good job of collection, handling, spinning the blood down, you remove variants due to collection and handling, many of these biomarkers of today for nutritional status are quite reproducible. But there are some exceptions. So for example, vitamin C is difficult. Even though it's above 0.4, it performs not as well as some of the other vitamins. And then if you look at some of the minerals or the elements here, copper is quite reproducible, but look at iron. I mean, iron is measured readily in clinical practice, yet the reproducibility, at least in our hands, is quite poor in older adults. Now, if we just take a snapshot at the actual nutritional status on some of these key nutrients in this pilot study, on the left, you have all the participants that were in the study, and then each column has a nutrient biomarker. And then based on existing literature or known deficiency guidelines, the shaded area shows that it's suboptimum. Okay, and if you just look, you see a lot of suboptimum nutritional status in the setting of a major academic medical center. Okay, now I will say that what's interesting perhaps is that there's very little deficiency in the B vitamins. And maybe that's because that's part of standard of care. Clinicians are aware that, B vitamin deficiency, particularly vitamin B12 or folate, can present a reversible cause of a dementing illness that caught in time can be reversible. And you can see that with that kind of policy and standard of care in place, you see very little deficiency. But a lot of these are outside of standard of care, and for good reason. We don't have enough evidence yet to be measuring these regularly. But it's still important to note that there are likely a high prevalence of suboptimal nutritional status in these populations, and all of these are treatable if indeed we think they're relevant. Now these are nutrients that have robust transporter mechanisms in the brain. So you begin to build a case that potentially something like a nutritional risk index or some kind of validated assessment tool could really be useful. So then we took this validated nutrient panel into a larger cohort study, a well-established cohort study called the Oregon Brain Aging Study that was started by Dr. Jeff Kay, and it followed individuals that were exceptionally healthy, the oldest old, over a decade or more, and had annual visits on cognition and blood draw and subsets with neuroimaging. And many of them had participated in brain donation to support science and understand what led to features in their brain at autopsy. So the mean age of this study, these individuals, is 87. Now, again, these are the exceptionally healthy oldest old. So you might say, okay, well, you're probably not going to see very much relationship between nutrition and brain health in this population. But nevertheless, this is where we went to make the point. We applied a relatively sophisticated analytical technique to help us identify synergistic features amongst nutrients in the bloodstream, or what we call nutrient biomarker patterns. We identified 8 different nutrient biomarker patterns in the blood. 3 of those are highlighted here. The BCDE pattern, which was high in the B vitamins, vitamin C, E, and D. The omega-3 pattern, which is high in EPA and DHA. And this lutein and zeaxanthin high HDL cholesterol pattern. Then we used these nutrient biomarker patterns within each individual to then relate that to total brain volume and white matter hyperintensity volume, or the small vessel indicator of brain health, and then also cognitive function. And what we see here is that the BCDE pattern was associated, so those that had higher concentrations of the BCDE combination in their bloodstream had larger brains, okay? But that pattern was not related to the small vessels, the vascular aspect, white matter hyperintensities. On the other hand, the omega-3 pattern, so higher omega-3 EPA and DHA in the bloodstream was associated with less white matter lesion volume, or less cerebral small vessel disease in the brain. But the omega-3 pattern was not related to total brain volume at all, suggesting that there are distinct combinations of nutrients in the bloodstream that may be operating on different features of the brain. This is a summary of the results of that study, where each of the 8 nutrient biomarkers patterns are listed in the row, and each column represents a cognitive domain of executive function, memory, attention, visual spatial function, language, processing speed, and then global cognitive function. And then the brain MRI measures, total brain volume and white matter hyperintensity volume. Now, this was the first study to apply nutritional biomarkers in a rigorous way and relate it to cognitive function and neuroimaging. So what we are looking for internally within the study is consistency. And what I mean by that is that we want to see what would be most compelling is to see a pattern that's related to cognitive function and also a neuroimaging parameter that makes sense, okay? So we see that the BCDE pattern was associated with better executive function, better attention, visual spatial function, also global cognitive function. It was also, as I showed, was associated with larger brain or greater total brain volume. The omega-3 pattern was not related to any of these cognitive domains except for executive function and white matter hyperintensities. And what's interesting there is that we know, if we follow people over time, that as white matter hyperintensities begin to accumulate, you begin to see cognitive changes in executive function. So this is a very interesting link here. We didn't see a relationship with saturated fats. We didn't see a relationship with carotenoids. We didn't see a relationship with cholesterol. The omega-6 fatty acids, so higher omega-6 fatty acids were associated with worse memory, worse language, but none of the neuroimaging parameters. The lutein or lutein and zeaxanthin and HDL was associated with better memory, but none of the brain MRI. And then trans fat, so the trans isomer of the 18 chain link fatty acid, trans fat that you would see in baked goods, for example. So that in the bloodstream was probably arguably the most compelling result in that it was associated with almost poorer cognitive function and more brain atrophy or brain shrinkage across the board. I think what also is important to note here is that these combinations of nutrients have specific cognitive faculties that they're related to. Again, this comes back to this precision medicine or precision nutrition aspect. So in clinic, if you have somebody that's presenting with clear memory, short-term memory recall, would we be thinking about the BCDE pattern? Maybe not. Maybe we're thinking about the omega-6, lutein and HDL and trans fat. What if somebody has poor attention? If poor attention is being presented, maybe we need to be focusing on the BCDE pattern listed here, and then trans fat. So removing trans fat in the individual's diet, screening for that, making sure that that's the case, or encouraging them to make some lifestyle changes there. So this is, I think, a prototype for developing more individualized nutritional therapies in the setting of dementia prevention. Now, I think historically, the effects of nutrition had been presented as a magnitude that's very, very small. That the effect of nutrition or nutrients is not a large effect that can be measured. I would argue against that. And I think the reason that has been the observation is that it's the tools that we've had available to us to assess the relationship with nutrition. I also think that it depends on the individuals in front of you. The effect of a particular nutrient could be quite robust in terms of after an intervention if the individual is severely deficient. If the individual is not deficient, then there's little to no effect. And without understanding the person's nutritional status, then it's difficult to conclude. But let me go a little further here. So in this study, so if you looked at global cognitive function, okay, and you build a model with age, gender, education, the primary genetic risk factor of ApoE4, hypertension, and depression, that will explain about 46% of the total variation in global cognitive function. If you add the nutrient biomarker patterns listed here to that, it adds an additional 17%, explains an additional 17% of the variation. If you look at the neuroimaging parameters, it's even more compelling. Same factors, adding age, gender, education, ApoE status, hypertension, diabetes explains about 40% in total variation of total brain volume in the organ brain aging study. If you add the nutrient biomarker patterns, you almost double it, okay, to almost 80% of the total variation in total brain volume is explained by these conventional risk factors or known factors plus the nutrient biomarkers. So I think that begins to build a case of how robust markers where we're getting closer to the brain, understanding clearly what the brain is seeing, and using biomarker approaches can do for us in terms of moving forward. So I just wanted to mention that this study, which was published in 2012, has now been replicated by colleagues in France at INSERM, which is the equivalent of the NIH in France, led by Cecilia Samrieri, a close colleague, where they also found higher concentrations of vitamin D, carotenoids, and omega-3s associated with cognitive health. So we have confirmation in the US and in France. And why is this important? And I'll move towards that. But before I do that, I want to introduce a blood-based nutritional risk index that explains cognitive enhancement and decline in the multi-domain Alzheimer's prevention trial. So this is a study conducted in France that was a large randomized controlled trial, and I won't go into those details now because we're running short on time. But we assessed nutritional status looking at homocysteine, the omega-3 fatty acids, and vitamin D in 25% of the population in each arm. Okay, so it was a total of about 780 individuals. Sorry, 712 individuals. The mean age in the population was 75. 67% were female. And when we looked at the nutrient biomarker, the nutritional risk index that included homocysteine, vitamin D, and the omega-3s, we scored people based on thresholds for each of those. So those that had optimum nutritional status received a score of 0. And as each nutrient that you add on adds additional risk, so it's a nutritional risk index from 0 to 3. Now, those in the MAP trial that had a nutritional risk of 0, so no nutritional risk, okay, those are the people in the clinical trial that experienced the learning effect on the cognitive test during the trial. So those are the ones that during the trial, they were undergoing some type of blinded treatment, and then they were taking sequential cognitive tests, and they were learning from them and improving over time, which we see. But I don't think anybody has really shown that nutrition might be accounting for that. Now, those that had a nutritional risk index of 1, those are the people that were stable over time. Okay. Those that had a nutritional risk of 2, you start to see the decline over time. And those that had nutritional risk index of 3, or the highest nutritional risk in this study, had dramatically more accelerated rate of cognitive decline. So conclusions for that study, French elders with homocysteine levels less than, so we have clear thresholds here in the French population. So those with homocysteine levels that were less than 14 micromoles per liter, 25 hydroxy vitamin D, the commonly measured vitamin D, greater than 20 nanograms per mil, and red blood cell omega-3 polyunsaturated fatty acids greater than 4.8 as weight percent are the ones that sustain cognitive function with aging over 3 years. So these require confirmation in the U.S. population because the fortification of foods in France is different. The policy is different than the US, and that may be relevant. And I will just move through a couple of these. We only chose 3 nutrient biomarkers, but this could be expanded, and it may need to be expanded based on some of the data that I presented today. And there also may be some genetic factors that may be relevant. So maybe at the end here, I will just introduce 2 major clinical trial efforts that were partially conducted by Mass General Brigham faculty, Joanne Manson. These are the Cosmos trials. There were 2 trials that read out, one last year, one this year, where they were looking at cocoa extract and a multivitamin on cognitive function, and then another one here looking at multivitamin supplementation. This is the flow that I won't get into the details just due to time, but these are large randomized controlled trials testing these natural products in terms of how well they can, to determine whether they're effective in terms of slowing cognitive decline. In the first one, the mean age was 72 and about 60% were female. And then these are the results of the Cosmos Mind trial led by Laura Baker at Wake Forest. They saw no effect of the cocoa extract over the 3 years. However, the multivitamin was effective in slowing cognitive decline over time. And when they looked at people that at baseline had no cardiovascular disease history versus those that did, it appeared that most of the effect is driven by those that have cardiovascular disease history, meaning the multivitamin appeared to work better. Multivitamin mineral appeared to work better in those that had cardiovascular disease history at baseline. These are looking at, this is global cognitive function here on the left panels, and the bottom right, D, is looking at domain specific. And indeed, you see effects on episodic memory of the multivitamin and executive function, which is quite promising. So that's one large randomized controlled trial showing that a multivitamin mineral can slow cognitive decline in non-demented individuals over 3 years. Now that is interesting in itself, but the addition of a second trial coming out just recently within the last month, I think is relatively groundbreaking and probably deserves a little bit more press even. This is another trial, the Cosmos Web, okay? Large sample, 3,500 people. And here they see mean improvement on immediate recall as early as the first year that's sustained over time, okay? So a multivitamin mineral. So what's in the multivitamin mineral? So this is a cross comparison between the Cosmos Mind multivitamin mineral in both trials. The nice thing is that they use the same formula. And what I have highlighted in red there is the nutrients that we had identified previously in terms of these nutrient biomarker patterns, both the BCDE pattern and the lutein zeaxanthin pattern. So those nutrients are enriched in this multivitamin mineral formula that was effective in slowing cognitive decline in 2 large randomized controlled trials. So in terms of dietary patterns associated with healthy cognitive aging, I just wanted to introduce, if you're not aware, of my close colleague, who Dr. Martha Claire Morris, who sadly passed away early in 2020, just before the pandemic. She was not only the co-founder with me of the Alzheimer's Association iStart professional interest area on nutrition, metabolism, and dementia that we started in 2015. But she's really been a leader in terms of understanding dietary factors related to Alzheimer's disease risk. And these are really 2 landmark papers of hers showing that the Mind diet that she has developed, which is a combination of Mediterranean style diet and the DASH diet developed by Frank Sachs here at the School of Public Health. Dr. Morris is a graduate from the School of Public Health here at Harvard. And in the left panel, it's showing reduced incidence of Alzheimer's disease in those in the highest tertile of the Mind diet compared to the lowest. And then looking at just cognitive decline with aging, those in the highest score of the Mind have significantly slower cognitive decline over time compared to those that do not adhere to the Mind diet. So if we look at these different scores here, I'm highlighting here the top score. So for those to get into the top score, the most neuroprotective Mind diet, this would involve green leafy vegetables of greater than or equal 6 servings per week. You can go through here and ask yourself, do I do I get 6 servings or more per week of green leafy vegetables or other vegetables or berries? Am I greater than or equal to 2 servings per week of berries? Greater than or equal 5 servings per week of nuts? Olive oil primarily is my primary cooking oil. Less than 1 tablespoon per day of butter or margarine, cheese. So each of these food groups, you can go through the details to understand whether or not, personally you have a diet that's associated with less cognitive decline or incidence of Alzheimer's disease. The details are really here. These green leafy vegetables, what are they? They're kale, collards, greens, spinach, lettuce, tossed salad. Other veggies are listed here, squash, cooked carrots. So these are what people are eating. The berries only included strawberries, okay? Fish, tuna sandwich, fresh fish is the main dish. This does not include fried fish cakes, sticks, or sandwiches. Red meat and products, so cheeseburger, hamburger, beef tacos. So the red meat products here, less than 4 meals per week. Also includes 1 glass of wine per day in her MIND diet, whereas you're at higher risk if you're greater than 1 glass per day or you never drink wine in the Rush University cohorts. So with that, I just wanted to provide some of these relatively large efforts that a group of us has been working over the last 5 years, I would say. Not only pushing forward our understanding of cerebral bioenergetics and how nutrition may tap into preventative therapeutics around Alzheimer's disease, a major nutrition for dementia prevention working group that was supported by the NIH, and a roadmap for future studies in nutrition and dementia prevention that's published in The Lancet. And then also precision nutrition for dementia prevention, looking at genetic factors. Here's summarizing some of the studies where ApoE4 genotype may be relevant. So the last thing I want to say is that for anybody that's interested in learning more, the Alzheimer's Association iStart PIA that we have developed now includes over 700 scientists around the world. At each of the Alzheimer's Association international conferences, we have featured research sessions strictly focused on nutritional metabolism and dementia. Prior to 2018, there had not been a featured research session specifically dedicated to nutrition. Now it's in the mainstay. There's 2, 3 maybe. So this is an exciting place to be part of. There's postdocs and graduate students. There's people in industry involved. So please have a look at that. And with that, I will stop. I believe I've gone a little bit over time, but I'm happy to stay for a few minutes for questions. Thank you.
Thank you so much, Dr. Bowman. We do have time for a couple of questions. We have an audience member who grew up in the 50s and 60s with what they considered good early nutrition, although carb heavy. In the recent years, they are learning to eat healthier as much as they can, taking supplements, eating pretty clean, avoiding processed foods. And more recently, however, they are more physically challenged in mobility and have long-term inflammatory conditions in their body. They also have a family history of dementia. With that, is it too late to preserve their cognitive function at the age of 76?
Well, that's a tough question, to answer. I think, first of all, you need to have a good relationship with your primary care doctor, and ask these questions. Whether or not it's too late, I personally, based on my experience over the last 17, 18 years in the Alzheimer's field, focused on nutritional neuroscience, I don't think it's too late. I think that there's opportunity or that nutrition has a role in each stage of the development of a dementing illness, whether or not it's something to maintain weight in an older individual, or to prevent agitation and behavioral issues. So I don't believe that it's too late. I think that the challenge is that in individuals that really begin developing dementing illnesses, compliance and adherence is a major issue. So it requires a team approach that is more difficult than in earlier stages of life, where the participant themselves can be much more proactive.
Thank you. And we have one final question. What are your thoughts on taking a multivitamin mineral versus getting these nutrients through food in regard to their benefits to our cognitive function?
Yeah, great question. So I think in general, food is the best way to go. There's no doubt about that. Meaning, you want to go the extra mile and figure out what foods you need to be eating that are dense in these particular nutrients and make those a regular mainstay of your diet. Now, with that said, what I would like to see, and what I'm, and this is why I've been an advocate for this nutritional risk index, is that a lot of standard care at the primary care level, or even in the specialist level in neurology, we don't have great tools for assessing whether or not somebody has optimal nutrition for their brain. So without that information, so for example, if somebody came to me and we identified some nutritional approach that they could implement, it would be based on a blood test to see where the individual is at that point, or some type of dietary assessment if they're cognitively intact, that, to get some understanding of where they are currently in their diet and their nutritional status, the nutrition that the brain sees. And then with that information, provide some guidelines, and then have a follow-up in maybe a month, maybe 3 months, and retest. If the individual is not getting to those optimal levels, I think you have to then be discussing how long can you let that suboptimal nutritional status go before you intervene and just cover the risk in terms of reducing the risk. So I think that's a case-by-case basis, and one that, it's an important conversation to have with your primary care doctor.
Thank you so much. So we are at time. Before we end today's session, Dr. Bowman, do you have any final thoughts you'd like to share with the audience?
I'm very excited to be part of this community here at Mass General Brigham and at the McCann Center for Brain Health. For those of you that are interested in the content that was covered today, please follow us at the McCann Center and the clinical trial efforts that we have ongoing. We have a robust team focused on vascular aspects of brain health. And we have some terrific directors of our center that are really dedicated to moving the needle of early detection and early intervention in support and promotion of brain health.
Thank you so much, Dr. Bowman. And for everyone joining us today, thank you so much for taking the time to join us. As I had mentioned, today's session is being recorded. If you're interested in viewing the recording, you may visit the Blum Center website at massgeneral.org/Blum-Center. Thank you so much, everyone. Have a lovely rest of the day.
Terrific. Thank you. Take care.